Welcome to Kentucky Tonight. Good evening. I'm Renee Shaw. Thank you for joining us. Our topic tonight, whether or not Kentucky should legalize medical marijuana. Our guests are State Representative Jason Nemes, a Republican from Louisville and sponsor of a medical marijuana legalization measure now in the session in the General Assembly this session. Dr. Danesh Mazloomdoost, a pain and regenerative medicine specialist. Dr. Jeffrey Block, an anesthesiologist with training in pain management and addiction. And Ed Shemelya, National Coordinator of the National Marijuana Initiative, a branch of the High-Intensity Drug Trafficking Area Program run by the U.S. Office of National Drug Control Policy. We want you to join the conversation tonight. Let us know your questions. Tweet them at KY Tonight, KET. Send an email to kytonight@ket.org. Use the web form at ket.org/KY Tonight. Make sure to check the box that says you're not a robot, or give us a call at 1-800-494-7605. Please include your first and last name and town or county on all messages. So welcome, gentlemen. Thank you for being here. We won't take a raise of hands of who came in the furthest. We had several of you traveling, London, and we're welcome Dr. Block, who's come in from Miami. So thank you. And you'll be testifying this Wednesday at the House Judiciary Committee on this very bill. So thank you for being here. Before we get to you, I want to go to the bill sponsor, Representative Nemes, who's been here before on this topic almost a year ago at this point. 34 states, is that correct? And the District of Columbia have legalized medical marijuana.
That's right.
And so you have evolved on this issue. And as you told us last year that you were against this before you were for it.
That's right.
Quickly, what changed your mind and what's the main tenets of this year's version of the bill?
Well, Renee, I think my road to supporting this has been the same as a lot of people in Kentucky and a whole lot of legislators. Now there are well over 2/3 of the members of the House of Representatives that support this bill. We have over a majority of the members who've co-sponsored the bill. For me, I was against it. I've never smoked marijuana or taken any illegal drug in my entire life. I'm against them. Not the kind of thing that I was associated with. So I was contacted by about 8 constituents, and they asked me to meet with them. And I thought it was my duty to look them in the eye and say, here's the reasons I disagree with you. And as I was doing that, and Renee, I'll never forget it, I was telling them my beautiful, well thought out reasons. His mother leaned forward and she grabbed my hand and she said, Jason, just listen to me for a second. And then I listened to her as she told me about her child who was in the stroller next to her, had a condition that caused seizures, and she was getting illegal drugs, bringing it in from another state, marijuana. And we went around the room, and all 8 of them told me their stories. They look just like us, just regular Kentuckians trying to do right, trying to feel better. And I thought to myself, you know, I may not be right. I think I am, but it at least shook me enough to look into it. So I read a ton of studies. I've talked with a whole lot of physicians and nurses, and I was wrong. And now, not only am I supporting it, I'm fighting with everything I have to get it passed because it's the right thing to do for our people.
So as I mentioned in introducing Dr. Block, that this bill is coming up for a hearing, for a vote on this Wednesday.
That's right.
In the House Judiciary Committee. You feel good about the votes there, and you feel good about the votes on the House floor, and you feel good about its chances in the Senate.
I don't have a doubt about the House. You know, it came out of committee last year 16-1. The support has only improved. And so we'll come out of the Judiciary Committee very strong. And then we're early enough in the session now to where it will get to the floor in enough time to not only pass it out of the House, but go over to the Senate, where I think it will be successful. We heard 2 weeks ago, sitting right here, President Stivers, who's a very thoughtful and smart man, said that there was a narrow path forward in the Senate. Well, I'm here to tell you that House Bill 136 is that narrow path forward. And I believe that we'll get it past the Senate as well.
So before we have you kind of run down and tick off the details, I want to go to Mr. Shemelya here because you've probably read the original version, and there are some changes that will be presented in committee on Wednesday that we'll talk about. But just based on what you know about just the general concept of this bill and what you've read about the bill, where do you stand?
Well, you know, when you look at this holistically, the issue that I have and we have as you examine the 33 states plus the district that have done this, first and foremost, the thing that I want to mention is basically what we don't have and what we see across the country. There's absolutely no quality control with respect to this. That's the first fundamental
And what do you
problem.
mean by there's no quality control?
The ability to make sure that the unintended consequences don't occur with respect to those that are getting access that aren't intended to do that. When you look at it from a regulatory standpoint, in every instance, regulation is failing. That's first. Secondly, the standardization of composition of the product. And what I mean by that is when you look at this product, it varies from producer to producer, from grower to grower, depending on what they do. And then when you look at the bill's composition here, now we're not allowing smoking, but we're allowing concentrates. What solvents are they going to be using to do in the extracts? That's number two. The third thing is, principally, is there's no standardization of dosage with respect to specific illnesses here. So how is a patient supposed to know, and it'll lead to my last point, when there isn't any standardization of dosage for these illnesses? There's no prescribing information. I go to dispensaries all over this country, medical and recreational, and I walk in there and you see a placard, and it lists all of the recommended illnesses that are approved by that state. Then it tells you what product that is acceptable for treating that particular illness. And lastly, and this is the critical linchpin of the whole thing, and the reason that we are so concerned about this, first and foremost, there are no high quality long-term studies on the efficacy and safety of this substance. Absolutely none. They don't exist. There's the first need. No doubt this plant has medical value. I do not dispute that at all. We need research into this, and therein lies the problem. We have a lot of anecdotal stories, and we have really short-term research that doesn't have a large cohort there, and we need the high-quality research to determine the efficacy and safety, and that's our principal concern with this legislation and the other 33 that are across this country.
Same thing. So, Dr. Block, I want to go to you and ask you about the efficacy of this, and that it has been anecdotal. And we've heard stories of people who say that they've had some therapeutic benefit by using medicinal marijuana, but where is the actual proof and empirical evidence that that's actually the case?
It started to evolve over the last several years. And in particular, in contrast to what my colleague has just mentioned about not having evidence-based data, you're absolutely correct in that anecdotal reports are not the same as data. The plural of anecdotal is not data. Such in that way, when we look at a recent report from the National Academies of Sciences, Engineering, and Medicine, this was a commissioned federal study from early in 2017 when released, it did show that there is evidence-based data for a limited number of qualifying conditions, not the 30 or so you may see in certain states, but for particularly nausea and vomiting, specifically from chemotherapy, but you could extend that to wasting disorders. It's appetite, that's what people think about with it. Multiple sclerosis has muscle spasms, which in most patients, 90%, are debilitating. It helps that. We know that from evidence-based data that actually is not simply only conclusive for the nausea and vomiting, substantial for chronic pain. And that's the big one, because that's what 90% of authorizations in those states which have legal programs recognize, but is easily exploited. Doctors such as Dr. Danesh and myself here, we're trained in that, and we understand pain perhaps differently. It's not a diagnosis, it's a qualifying condition, but it's a symptom of many diseases and qualifying conditions. There is a substantial amount of evidence-based data, as evidence from that report, that got my attention. And I do feel differently about it now because those qualify as well as epilepsy. You hear about epilepsy and what the representative mentioned with his particular constituents. That now has a specific drug that has been FDA approved that is plant-derived. It doesn't contain THC, the one that's psychotropic and psychoactive, but it does work, and there is conclusive evidence-based data for that. So if only on those bases, that is in difference to the primary definition of Schedule 1, which says there is no known medical use.
So I want to go to Dr. Mazloomdoost and get your opinion from one doctor to the other. Do you buy what he's saying?
I don't think it's a question of buying what he's saying, because I've had a few conversations with Dr. Block, and a lot of what he says is very evidence-based. He's done a lot of research in this arena. The concerns that I have is when you have chronic pain as a diagnosis, there's so much that can go wrong with that, and we see that in many of the treatments that are currently out there, because it's an area of medical science that there's been a vast array of misunderstanding. And when you're talking about chronic pain, you're really talking about 3 different physiologic systems, be it the biomechanics of the body, the nervous system that's transmitting it, and the brain that's processing those signals. And chronic pain is really involving all 3 of these, making it a very complex, very, I would say, a dirty diagnosis. So in order to have a vague diagnosis like that with another medication that's going to be involved in the treatment protocols of that, there really needs to be a lot more understanding behind it. Because if you were to ask me today, what dose of marijuana would you prescribe for that, I really wouldn't, and I will admit, I'm not 100% well-read on the subject, but I'm fairly knowledgeable about this. I wouldn't know what to write for, let alone my colleagues who are seeing this on the front lines and seeing patients coming in as a general practitioner. It would be very hard for me to even advise them on what to do, let alone do something myself. That, to me, is a little bit of a nebulous area that really warrants clarification.
And Dr. Block, to that point, before I get back to you, Mr. Shemelya, about dosage. So how do doctors go about that? How do you decide what's best for that patient to not overprescribe and create possibly an addiction or go into psychosis?
Well, as my colleague brought up, dosing is important. And we know very little about really two things: dosing, effective doses across the general arena, but also about the long-term effects, which was alluded to in terms of wanting, we call longitudinal studies, follow the same patient over a period of time. The concern with dosing, not unlike other medicines, is that the training that goes along with cannabis should be one that starts with the lowest available dose and builds up slowly to find the effective time. If you look at the package inserts, the physician's instructions from those few drugs that are legal in other parts of the world, of which there are notably 2, they all have the package insert recommending you start low, go slow, that over a 2-week period, if you don't see the desired result, it's a failed treatment, try something else. So it's the rationale of how you approach it by treating it responsibly, by starting with the lowest effective dose and staying there.
And for 2 weeks and then escalating if necessary.
That's the package insert for one particular medicine, yes.
Mr. Shemelya.
You know, he hit the point dead on, and he talked about the epilepsy drug Epidiolex that was approved in 2018. That's how we do medicine in this country. He's right. That's the first plant-based derivative marijuana schedule. It's now a Schedule 5 drug, but GW put it through the clinical trials of the FDA, and they did the longitudinal studies to determine the efficacy and safety. And that's how we do medicine. And it's all we're asking with this drug. And let's subject this drug to the rigorous trials that we do all other substance in this country. It doesn't get a pass through state legislatures or, God forbid, voter ballot referendums. And that's how we've done it in each and every instance. And that's all we're asking here.
So that takes, what, 5.5, maybe
it takes
6
time.
years?
And
for
part of
those
the problem,
patients who traditional medicine has not worked, that's 5 years. It could be too late for them.
I understand that. I understand that. But this is how we do medicine in this country. Maybe we need to change that process and speed it up. Part of the problem, it's a Schedule 1. That's the first problem. Probably needs to be a Schedule 2.
So I was going to ask you, do you favor Congress reclassifying that
Obviously,
as a Schedule 2?
You have
And
to have that discussion after, particularly with Epidiolex being rescheduled to a 5. And we know that looking at Epidiolex, that there are going to be other compounds within the 100-plus cannabinoids in marijuana that are going to have medical value. And the Schedule 1, you know, it creates the onus burden on doing research. It probably needs to be rescheduled. In all honesty, it probably does.
Dr. Danesh, do you think it should be rescheduled?
100%. 100%. And I think across the board in medicine, you'll find a lot of clinicians who would agree with that notion that if we can reclassify it and if we can start to study it and better understand the properties of it, because it is a very complex concentration of chemicals. It's not just one molecule like a drug would be. And I recognize there is some concern about the synergy of it, meaning that multiple medications need to be present for there to be value. But unless we have the ability to start studying this, how would we ever know what combination of those medications are needed, what concentrations are needed to get the best out of it with minimizing the risks?
So there was a question that came in specifically for you, Dr. Mazloomdoost. They ask, should patients be jailed for consuming or possessing cannabis? If no, how should Kentucky regulate it? The federal government is passing the buck and supports patients being jailed, end quote.
So I would defer that to some of my legal colleagues, but you know, there are stratifications that you could look at. There's decriminalization. There's use of it as an intoxicant. There's medicalization. My position is that if we're going to call something medicine, then it needs to go through the rigors that we go through when we give medicine. Otherwise, we're marginalizing what it means to be a physician. We're marginalizing what medicine stands for, because when you call something medicine, you're connoting a level of evidence behind it and a level of safety which until we can kind of come to consensus on as a medical community, it would be undermining the notion of what a medicine is in the minds of the public.
Okay, before I go back to Representative Nemes to get some more details on the bill, I'll have to follow up with you, Dr. Block, and ask you, do you think that marijuana is medicine?
I think that marijuana, which I don't prefer the term anyway, it's a mongrel term. Cannabis is undergoing, as was just inferred by Dr. Danesh, a process we call medicalization. It's that process which otherwise previously misunderstood or compromised diagnoses and understandings come to be part of the domain of medicine and recognized as such. That's a process. It doesn't happen instantly in a moment. It's going through that process now. And it's critically important to have unfettered research without the constraints, for instance, that we're saying that Schedule I presents. As far as its applicability now, the legal conversation on this, in the mid-1990s is when the mechanism of action on how it works was determined. That's when I really took notice, because no longer was it an issue of social injustice or a right to access. It was one of medical science. That changed things markedly, and that's actually around the time that California became the first state to recognize a medical law.
If I might, Renee,
yes,
one of the things that it's replacing are things that have been through the process that are killing our people. I mean, I don't want to be disrespectful to the FDA. I hold them in high esteem. But one of the biggest problems we have in Kentucky is our opioid scourge. I have people in my family who have died from it, from overdoses. And so it's hard for me to sit still when I hear it's got to go through a 5-year process and everything will be great. When these drugs, which have already been through the process, are killing our folks in droves, causing families to be destroyed and communities to be dilapidated. I mean, so excuse me if I don't hold this process up to the top level of everything as it being sacred. What I do know, and what we learned in the Journal of American Medical Association last summer, that was a study from a University of Kentucky physician, Dr. Wynn, is that in medical marijuana states, when physicians have an option for medical marijuana, their opioid prescriptions go down 8%. There are many of other studies that say it goes down even higher. But let's just stick to the University of Kentucky physician, a doctor, that was published in the Journal of American Medical Association, not Cannabis Today, JAMA, which is the most high esteemed, my understanding, medical journal we have. And so it needs to go through the process, and that's why part of my bill has 2.5% of any of the proceeds, the licensing fees and so forth, goes to a university, presumably University of Kentucky, hopefully Western, but goes to a university in Kentucky to study the issue. And we also have put together a board of physicians and a pharmacist and 4 patient advocates, and their role will be as the gatekeeper. Add things to the list when the science says it, take things off the list when the science says it. And so we're trying to do things responsibly, but I'm not going to hold up the FDA as saintly here, because you know, I have family members, and most people watching today have family members that have died off of drugs that were peddled as non-addictive, approved by the FDA, and are destroying our state.
And to that point, Dr. Mazloomdoost.
So yeah, I think there's a number of things that are being overlapped in that statement. So FDA never said that these medications are not addictive. Right. They always said that they were addictive.
Yes. They were advertised that way.
Advertising and what it was cleared for, what the medical science behind it said, are two very different things, and that's something that I've testified about in opioid trials, is that the way the medications were represented were not scientifically based. They were not what the FDA had cleared. And it was a gross misrepresentation of this field that I have spent my entire life studying. The fact that opioids were never appropriate to be prescribed in the first place does not mean that simply adding another agent will take its place. They were not appropriately prescribed from the start. But the solution to that is going back to the basics, understanding what is pain, understanding how we treat pain, that it's not just something you can mask with medication, whether it be opioids or cannabinoids, that it's really understanding the root causes and starting to address those things. And when you start to dissect it out like that, you will find that there are conditions that endocannabinoid system is affected and would be beneficial. but it's not universal. It's not like you can just simply replace an opioid with the cannabinoid and get better effects.
Right, and I don't think I didn't say anything to the contrary there. What I'm saying is that the physician should be able to make her own decision on how she treats her patient. She has to be approved in the bill by the Kentucky Board of Medical Licensure. Can't just be anybody. They have to have a bona fide relationship with that patient, and so they know what's best for the patient. They have to be educated on the matter, obviously, as Dr. Block has said. And so it's best left in the hands of the physician that for her to treat her own patient.
In theory, I agree with you, but in reality, we just don't have that information. Like I said, if I were to be asked, what do you prescribe this patient for this condition, as much as I know about pain, I wouldn't know what to prescribe. Nor would I jump to an opioid to begin with. I think that we had a very, very low threshold, an unnecessarily low threshold for prescribing opioids, which is not the same thing as states where cannabinoids have been legalized, opioid prescriptions drop. It's not a one-to-one relationship. Just because this medication was inappropriately prescribed to begin with, and now clinicians are prescribing it less and instead prescribing a different medication, does not necessarily mean that this is the reason that people are taking less opioids. Neither one may be appropriate to begin with. So whether they were actually getting a benefit from the cannabinoid or the opioid is really the question that we need to answer, rather than saying, let's just replace opioids with cannabinoids. We need to understand the root causes.
You're watching Kentucky Tonight, and we're talking about legalization of medical marijuana in Kentucky. So if you have a question, tweet us or email us, and we'll be sure to get that on the air. So we want to put a pin in it right there, because I do want to make sure that we get the basics of the bill down and understood. So this would not be that you would get free license to smoke pot because you have a chronic condition. That, as you mentioned, there would have to be an established relationship with your physician. I assume that patient would have had a series of physicals or things to determine their medical condition, and then they go through a process of getting some type of registration card. Is that correct? In order to carry medical marijuana on their person. So tell us about how that works. Yeah.
So from the patient's perspective, they have a bona fide relationship with their physician, and their physician, provided that physician's been approved, and they have a condition that qualifies, and the physician thinks that particular patient would benefit from it, they'll get a card. They then take that card to a pharmacist for the first time before they can go to a dispensary, so the pharmacist can make sure that there's no problems with what they're already taking, no contraindications, and then they can go to the dispensary. The dispensary is regulated by the Board of Pharmacy. The dispensary technicians are certified by the Board of Pharmacy. The dispensary is also overseen by a pharmacist, and so all in this is infused all around this bill is Dr. Block mentioned, the medicalization of cannabis, and that's what this bill is supposed to do. And that's from the perspective of the patient. From a physician, they have to obviously be approved from the Kentucky Board of Medical Licensure, and every time they make the recommendation to any patient, they log it into Casper, a Casper-like system if Casper can't do it.
And this is the electronic prescription drug monitoring program.
That's right. And who has access to that? The physician has access to it, the pharmacist, the dispensary, and law enforcement has access to this information. We're not trying to hide anything. It is not smokable anywhere. You can't smoke it. And there's no...
So what kind of form is it in? Gummies, brownies? What are we talking about here?
It can't be any form that is smokable, and it can't be any form that's attractive to children. Okay. And so gummies, colorful gummies will be out. They will not be allowed.
So anything edible would be out?
No. It can be edible. It just can't be attractive to children. We don't want to have a bunch of colorful products that are attracting children to whether their parents have them or whatever. And so, it comes from tinctures, it comes from salves, it comes from oils, it can come from
or
pills.
Pill form,
pills, that's right. Suppositories. There's a lot of different ways to get cannabis into the body. It's just that there's no combustion. Right.
So you don't put any kind of dosing restrictions in the bill, or do you? Does it address that in the bill?
No, it doesn't. The cabinet, the Department of Health is the organization that's going to run it, the Cabinet for Health and Family Services. And they'll come up with regulations to address those types of things.
And that's different from the original bill that I think had the alcohol beverage control organization. So you changed it to the health cabinet. Is there a particular rationale for that?
Well, it's medicine, and so my colleagues wanted it If we're going to have it as medicine, we want it to look, feel, sound, everything like medicine. So that's the reason we've done it. The reason we put it in ABC before was because they already have investigators that go out, and they already have a lot of the resources that would be necessary. We put it over into the cabinet, into the Department of Health, because it sounds like that's where it needs to go. The professionals are already there. And so it can be regulated in a much more responsible way, a medicalization of cannabis.
Right. So last year you had a home grow provision that allowed qualified cardholders to grow up to 6 mature marijuana plants and 6 seedlings for personal use. Is that in the bill this time?
It's not in the bill. Now, that was it was qualified cardholders who are indigent. One of the things that I want to do is recognize that Kentucky is a very poor state. And so I want the access, because I believe, as even my friend Trooper Shemelya has said, that no doubt it's had medical value. It's a quote. There's no doubt about that. And so what I want to do is, if we believe that to be true, and I think all 4 of us believe that to some extent, then I want it to be available to Kentuckians, and not just Kentuckians who are lawyers like me and who have wealth, but I want it to be available to poor people. And that's why I wanted self-grow in there. But self-grow is not in there this year. I couldn't get it past the House with that in there, and so it's out. No smoking, no self-grow. And
so you think those were 2 of the opposition points that you think will clear the path this time around, in this narrow path that you think this bill presents?
That's right. No doubt about it. I think, look, I'm not for recreational. I have 3 sons. I don't want them touching marijuana. If they need it for medicinal purposes and they have a physician that tells them that it would help them, then I think I would do what everybody else here did. I'd get it. And so the law ought not disallow that. But I think that's 2 of the major barriers that we had last year that have been removed.
So what kind of safeguards are in your bill to ensure that we don't have the situation of the pill mills that we had a decade or so ago? What are the safeguards for that?
We've already spoken about a bunch of them, and that is that the physician has to be approved and regulated, oversight, from the Kentucky Board of Medical Licensure, which does, by the way, a very good job. They used to not do so well. I practiced before the KBML, represent doctors before the KBML, and they used to not be very harsh on physicians. They are now, appropriately so. And so the KBML is going to be overseeing the doctors to make sure there's not misbehavior. So that's one. The law enforcement has access to all information, not only the Casper-like system, but they can go into the facility. And so I always say, where the lights are bright and the cops have the keys. The grower, the processor, and the dispensary are regulated, are licensed. Every product that someone has to be in packaging that's appropriately labeled. There's a litany of protections to make sure that we don't slouch toward recreational, if you will.
So are there any protections for cities or counties who don't care to have dispensaries in their locations? And there is, I'm sure, a process by which they could have that petitioned and put a question on the ballot.
That's right. And so we have opt-out and opt-in. So if a particular county or city doesn't want to be involved in this, they can opt out of the program and not allow anything to occur in that county. If that happens, then if a city would like to within the county, wants to, let's say I represent Oldham County. Let's say Oldham County, which I don't think they will. I know the numbers in Oldham County. I've talked with all the legislators, the county government officials. But let's say Oldham County opts out, but LaGrange wants to opt back in. They can do that. But we've protected local control here by allowing counties and cities to opt out and opt back in.
Okay, so let's hit a couple of these questions here, shall we, that have been coming in. Lots of email questions about dosing standards, and this coming from Bren Blankenship of Lexington. Are there dosing standards in place for other drugs that are used to manage conditions that medical marijuana can possibly manage with less personal or societal repercussions? Are they mandated by the legislature, or instead do we just adjust dosing by the patient and individual situation? A couple of questions there. We've kind of talked about dosing. Dr. Mazloomdoost, I'll get your opinion, then Dr. Block.
Dosing, like I said, we don't really have any guidelines or any recommendations. We don't have the studies that can tell us, this amount of medication in this situation is appropriate. And as was mentioned before, we're not talking about just one medication. You're talking about a multitude of medications where we don't know the right combination, we don't know the dosing. So it's very difficult to put that onus on clinicians, because in essence, we're just prescribing to effect. And when you're talking about subjective problems like pain, it's very difficult, even for the individual, to really be able to differentiate today from yesterday. With the added confluence of there being a placebo effect, and psychotropic medications will have greater placebo effect. And I think Dr. Block and I have talked about this as well, that the dosing recommendation, that the dosing even though the dosing recommendations are not out there, that the studies that show benefit are of much lower doses than what's currently out there in the community.
Dr. Block?
Well, that's true, and that's why I mentioned before about that basic mantra of start low and go slow. But not meaning to shift the question too much away from your audience, but we're not naive. We understand this is a position and a concern of public health. So if we look for trends that are going along these past several years, in the last 15 years, drug abuse is manifested through a public health concern, which are avoidable accidental deaths, has gone from the 9th most common source of preventable death to now being the 6th. It's just surpassed motor vehicle accidents as well as gunshot wounds. So the urgency to deal with this is being real, and a lot of those are from opioids. So there are other things other than opioids and cannabis, but the issues aren't going away without physicians' input with other things that we can do, perhaps things safer and better.
Yeah, Mr. Shemelya.
And I think one of the key issues with the bill as it is right now is the fact that when you're basically concentrating marijuana. And what we see with today's marijuana, with the evolution of marijuana in this country, particularly after Colorado recreationalized in 12, we've seen an explosion in potency to where we're now seeing in Colorado, on average, THC in the flower over 20%. And
why is that significant?
Well, that's significant because when you look at THC 10 years ago, the average was in the low teens. And now, but what you're doing, though, is when you concentrate and you're extracting in the forms that are allowed in this bill, that's where the highest concentration of THC will exist in every one of these forms, whether they're waxes, they're shatter, they're oils, they're tinctures, edibles that are infused with THC. It goes against what the doc is saying about start low and build high. We're actually going to be starting high in the first place with respect to THC levels because
of this. So what's the actual THC level that you allow
There's
in the bill?
There's a misunderstanding here. The concentration, the percentage of a given THC, in this case in cannabis, is just that. You don't have to give as much. It means it's more concentrated. What I'm saying is you give totally less in terms of not percentages, but what we call milligrams. That's the actual dose.
But we're looking at what the typical patient is doing is in dabbing, and particularly with oils and vaping. They are taking who knows how much, because this is the beauty of this, is the patient gets to determine the frequency that they want to dose and the level they want to dose, because yes, they do. You can't stop it. You say you have a bona fide physician relationship, but when I walk out of this doctor's office, I do whatever the heck I want to do with this particular drug.
Yeah,
that's not true.
If the patient says my pain is still as bad on a scale from 1 to 10, it's still at a 10, doctor, it's been 2 weeks, let's go up. And they come back 2 or 3 weeks later and say it's still at a 10. I mean, that's really subjective.
Well, the physician, first of all, has to understand who her patient is and has to treat her patient. But you can't go out with a card and just get whatever you want. It's regulated how much you can get. So the argument of Colorado, which we always bring up, Colorado is recreational. We're not going to recreational in Kentucky.
They're still medical. They have 89,000 medical patients.
I understand that, but
yes, they do.
I didn't say they didn't.
It's the same product too.
No, I didn't say they. I didn't say they didn't.
Product.
But you said that their potency in Colorado is out of control because of the
potency all over the country is out of control.
I understand. This bill, unlike a lot of states, even a lot of states' medical marijuana programs, has limits on potency.
What, 75%?
And we took it from many states and limited it.
75%.
So what is it in the bill, Representative Nemes?
75%.
It's 25 to 75. That's right.
That's a big gap, 25 to 75%.
It is, and it's to be determined by the medical professionals, not by the patient. And also, so if you're going to say all of these things in Colorado and other states, Oregon, we hear a lot about for the recreational program makes the product too potent. Well, then you should be for this bill, because that stuff is coming into Kentucky. We're not bringing marijuana to Kentucky. I mean, let's get over that.
We have an abundance of marijuana already in Kentucky.
That's right, and we have an abundance of Colorado marijuana in Kentucky. What every single product that you would get under this bill has been tested by a safety tester, right, to make sure that it's legit and not coming in from some other place. And if you have it, it has to be in a package. You can't just say, I got this card, and all of a sudden I've got all this marijuana, and this marijuana officer is allowed by this. Nope. It has to be in a card. You have to have a card. It has to be in a package that you receive from a licensed, from the Department of Health, dispensary. The product was tested, So at all levels, it's protected. And so if you think the potency from Colorado and other places is so bad, and I don't disagree with that, then that's an argument in favor of this bill, not against it.
So this email question, and we'll get right back to you, Dr. Mazloomdoost. Rick Beach from Danville, Arkansas he says Arkansas recently passed medical marijuana legislation, and the backers of that law have since made it clear their next objective is to legalize marijuana for so-called recreational and personal use. If medical marijuana is legal in Kentucky, will politicians write legislation that will prevent marijuana from being legalized for recreational use? And you say,
yeah, of course, it's illegal, right? And we always say, people say,
but people are concerned about a slippery slope. If you allow this,
so
the next thing to come would be recreational.
Right, Renee, I'm concerned about that as well. I'm not going to lie. But of the 34 states that have it, only 11 have recreational. So it's not a true statement to say that medical always leads to recreational. I don't think it will in Kentucky.
You can't be rec unless you're first medical. That is never, we've never had anybody go from nothing to recreational.
I don't know didn't Michigan just do that?
No, we've gone from, you go from nothing to medical. That's the model. That's happened. That's happened all 11 times that we have recreational. Medical's the model. And it is a slippery slope, because I don't doubt your intent is true, that you do not want recreational marijuana. I believe that 100%, but you won't be able to stop it.
No, I'll tell you this right. I'll tell you this right now. You can't find more legislators in the Kentucky General Assembly than are fingers on my hand that would support recreational marijuana. They're not there.
Yeah.
Okay, another phone question, and it's about, can the fees be lowered? Representative Nemes, Daniel Harmer from Louisville, asked you. In the licensing requirements for the dispensaries and in order to cultivate, the fees are substantial. He's wondering if they're going to go lower than that in the areas in Louisville, specifically like Portland area and the West End, where people have been affected by marijuana charges.
Yeah, so the fees are set at the exact place at which the LRC has told me will break even, because we don't want to make any money off this, because if you make money off of it, you're making money off the back of sick and poor people.
That's why you're not taxing it.
That's right. That's
for
right.
Sales tax.
At the retail, at the dispensary, right. And so we've come up with a number that will break even. If we make money, then we need to lower it. If we cost a lot more.
What is the number? I'm sorry, I don't know.
I don't remember the exact number. It depends on how much you're growing.
Right.
And I think for the cultivator, I think it goes up to $75,000 if you grow 50,000 square feet. And by the way, another protection, it has to be grown inside.
No outdoor grow.
That's right, no outdoor grow.
So a greenhouse or something like to that effect. Dr. Mazloomdoost.
So I want to posit another option, another alternative.
Okay.
Because right now we're talking about adding a lot of infrastructure. We're talking about taking a plant-based complex of chemicals, refining it, putting on standards where we're going to start looking at these as individual chemicals and see what the composition is going to be. So that's a lot of infrastructure that we're going to be investing into. Well, what's the alternative to that? The same thing we do when we produce a medication is put in the infrastructure that's going to be utilized to identify how to prescribe this safely, what doses are appropriate, when people should take it, so that you're not having to put the onus on, say, legal enforcement to go in and say, is this patient taking it appropriate or not? And then take it another position that if you're making this medication outside of the purvey of medicine, meaning that people are going to have to be paying for this out of pocket, well, it costs money to refine those chemicals, figure out what the appropriate doses are, figure out what's safe, and try to put that in the hands of the public. That's something insurance will never then pick up. It's something that research will not pick up, because if people can go out there and buy the medication on their own, what incentive does somebody have to invest the money into figuring out what is the appropriate doses, what is the appropriate dosage, what is the appropriate condition? So in other words, you're taking it out of the infrastructure that currently exists in how we see medicine, how we produce medicine, and you're changing the whole dynamic of it, which then you have to make exceptions so that people who can't afford everyday medication or are indigent will have to figure out a way to afford that as a source of medical.
That's a good point, Representative Nemes.
It is.
Have an answer for that?
Yeah, and a lot of so a lot of the money, I think is 13.25%, goes back to indigent access. And what a lot of states do, and Connecticut is one of the leaders in this area, is the companies that get licenses, part of their licensing application is how are they going to make it accessible to indigent folks. And so, look, it's not perfect, obviously. And one of the things that perverts the whole system is the federal law. And therefore, the insurance companies can't pay for it. Right. And so that's a problem that the 33 states and Kentucky soon, I think, will have to grapple with. And we are grappling with that. It's not going to be available to everybody who needs it, but it'll be available to a lot of people who need it, and it's unquestioned that it helps some folks. So
this question to you, this is from an epilepsy survivor and warrior, as he said. His name is Kevin. If medical marijuana is passed this session, when would it be legal?
Not soon enough. And so what it is we pass it, and then it goes into effect within 90 days after a signee dies. So that's early, mid-July. And then the governor has the ability to come up with regulations up until January. So there'll be a 7-month process where they're coming up with regulations. And then once the regulations are in, companies will be making will be making applications for licenses. And we anticipate that the first patient, if this bill passes this session, the first patient will be served medical marijuana in July 1st of 2021.
Which is a lot sooner than if the FDA approval process
of course,
5
that's right.
years.
Right.
Okay.
Yep.
So let me just look at a couple of questions here. Please ask the doctors how many marijuana overdoses occurred in medical marijuana legal states. This is from Mike, a tweet. So do we know if there is any connection to medical marijuana and overdoses? Dr. Block.
Lethal overdoses purely from cannabis, no. And that's because cannabis is unique compared to opioids. The part of the brain that controls respiration, that's affected in a negative way in stopping breathing that happens with opioids doesn't happen with cannabinoids because there are no receptors in that part of the brain. That's not to say nobody's ever died from having too much. Certainly driving off the road, falling asleep in those situations happens. But thus far, for motor vehicle accidents, in particular lethal ones, it's actually kind of hard to find controlled studies or even post-mortem where it's only cannabis by itself leading to a lethal car accident. So it's very different in terms of when you mention overdosing or addiction compared to other medicines, because people think that addiction means you can overdose and die from it. Yeah, you can
become addicted to cannabis.
Oh, absolutely. Roughly 1 in 10, but with concentrations from years ago was the accepted cited number there. But in that sense, it's more of a dependency, and that's a daily user. That daily user, though, also represents industry's target, because that daily user, even though they may only represent 10% of all users, represents about 60% of all consumption. And that's very germane to the recreational market.
Yes, go ahead.
And if I can add to that, we focus on overdose with the respiratory aspect of it because that's what we're seeing with opioids. And so there's this notion that overdose or the adverse effect of taking too much of a medication is death by respiratory depression. And that's not the only situation. There are a lot of medications that if you take in excess, the overdose of it won't kill you, but will give you complications that will dramatically alter your quality of life. And that's something that we are seeing, particularly with higher and higher concentrations available. We are seeing overdoses that aren't lethal, but have dramatic impact on the cognitive effect, on the mood and depressive effects thereafter.
And Renee, I don't want to step over this without commenting on, again, those kinds of concerns, which I share, are supporting of the bill, right? Because we're not bringing marijuana to Kentucky. It's already here. There are a lot of people who are already self-medicating, and this brings some standardization, some medicalization to their life, to the product, to their ability to take care of themselves or their wives or their children. That's what this does. This bill is designed to help folks. I want to get not only of what they're taking that might be bad or laced with other things. This won't be. It's tested. It's medicalized, if you will. But also, I don't want my constituents going to people who are hustling drugs, who they may sell marijuana, they may sell other things in a dark alley. I don't want that to happen. I want them to be able to go to their physician. I want them to be able to go to a dispensary and take care of their children. Everyone up here, there's not a doubt in my mind, if their physician said, your child has a condition, or your mother is going through cancer treatments, and this will help them, there's no doubt in my mind that each of us would do what we needed to do to help our mother. That's what I would do. I don't break laws. I barely even speed. My wife makes fun of me how slow I drive. But I'll tell you, if a physician told me that it would help my mom who's going through cancer treatments, I would break the law in a heartbeat.
Well, and to that point, Karen Lane of Rochester, Kentucky says, what kind of answers do you all have for a parent of a child with epilepsy who's been waiting for years, waiting for Frankfort to give their child some help, and children and adults are suffering while they sit around and talk about it? This is from, in the words of Karen Lane from Rochester. So I think you probably just dittoed her remarks. Mr. Shemelya?
Well, I can't. I'm not a physician,
Sure.
so I can't address
to your
that.
point, I think you were going to say
I guess
something
to Representative's point here, my principal concern is that, yes, I agree with you. That you would do anything that you could. If somebody in your family was suffering from one of these debilitating conditions, yeah, no doubt that we would do what we had to. But that's not a reason to enact public health policy. It's not a reason. It's not grounded in science. It's not grounded in longitudinal research, and it's not a reason to change public health policy because of that. What we don't know, and that's the problem with this drug. There's more about marijuana that we don't know than we do know, and there's the issue right there. And we're going down this road without a clear understanding of where we're going. It's like we're driving through a mud hole and expecting we're going to come out with a clean car. It's not going to happen.
Dr. Mazloomdoost.
You know, a few years ago, my mom had breast cancer, and vitamin C was suggested to me by another colleague, a functional medicine doctor, to be helpful for people dealing with breast cancer as far as, you know, remission rates and things. Vitamin C is readily available. It's not anything that's controlled. I could get it. I could give it to my mom. But there wasn't the science for me to go in and really know for fact that vitamin C is going to have a beneficial effect as opposed to a detrimental effect. There are theories that it could help. There are some studies that show suggestions of it, but it wasn't vast enough for me to say, this is something I'm going to help my mother get. The same thing exists right now with marijuana. I agree, there is medicinal value, no question about it. But what conditions it's helped with, how much does it take for it to help? How much of it does it take to be unhelpful? Because we know, for instance, with pain, there are thresholds above which it actually makes the pain worse. And when we don't know those things, I mean, I really commend the bill that you're putting out there. I think in the pragmatic steps, it's making some right decisions. But the challenge is that it's in an idealized world. Yes. Because you're asking the pharmacist, you're asking the doctor, you're asking KBML to help provide some guidance or clarity about how to use this medication. But the reality is that that clarity doesn't exist. So we'd essentially be creating some thresholds that, sure, it's to the best of our ability, but at the end of the day, it hasn't been vetted through the scientific process that gives us as professionals the confidence that we're making the right decision. And when we take an oath to do no harm, part of that is taking into consideration all the adverse consequences, all the unintended consequences, all the things that could go wrong, and try to make the best decision. And that's not always easy.
We don't know everything in the world on this. There's no doubt about that. That's why I put the board together to increase and decrease, put on and take off conditions that are qualifying. That's why we've got University of Kentucky doing studies. Yale University is now doing big studies on this in Connecticut, as well as a number of other states. But we do know some things, right? So while we're trying to get the sweet spot, we do know some things. One of the things we know, for instance, is that it's good for multiple sclerosis. I have a constituent in my district who came up to me and he said, "Are you Jason Nemes?" I said, "Yes." I had never met the guy before. He starts crying. And he says, "Thank you for what you're doing." Crying, a grown man, 40 years old. And he says, "Because I have MS." And he has muscle spasticity, obviously, that comes with MS. And he says, "And I took marijuana twice a week to help me get up and help me work so I can provide for my family." And so what we're doing, because we know it helps MS, that's a given already. So what we're doing while we're trying to get everything right and take 5 or 6 years is we're condemning that father, that Kentucky father, to break the law or feel bad or leave his state. And that's not acceptable. So and that's why about 90% of Kentuckians support medical marijuana, and that's why I think it's going to pass.
So you detail the conditions in the bill, or you also allow the doctors to use their professional discretion on what would best be served by some dosage of medical
marijuana. So we're having a
conversation
conversation right now about what conditions to include in the bill. Dr. Block has his beliefs based on those studies that he cited before, and so there are 4 or 5, I think. And then, so we're having a discussion on what conditions to include in the bill, if any. But the board will be there to determine if the science says that we need to add some, or maybe some that are on there need to be taken off now. And so it's a methodical, medicalized process.
Yes, Dr.
So let me ask you this. Stem cells have a lot of research that there's beneficial effects to it. I use stem cells in my practice to help regenerate joints, regenerate nerves that are damaged. But I'm currently not allowed to use stem cells in the spine to help people with MS, in spite of the fact that there's evidence behind the efficacy of doing so. And with the added advantage that this is actually starting to heal some of the lesions that are causing symptoms of MS, as opposed to using a medication that can help suppress the symptoms of those lesions. So are we going to create a carve-out for stem cell use in the spine as well? I mean, the problem is that when you start to look at these therapies that have promise, that have optimism behind it, and you start to make carve-outs for each of these new modalities of therapy, you're taking resources away from doing things the way that the process has been done for years. And no, it's not perfect. And yes, we have a lot of obstacles, like the fact that it's Scheduled 1.
Right.
But rather than put our forces, our efforts into creating loopholes or creating workarounds for the solution, let's start working on the actual problems that exist. If 5 years ago, when we started, we started all of these conversations, if 5 years ago we had down-scheduled it from Scheduled 1 down to a Schedule 2, we had started doing some research around it, we had fast-tracked it through the FDA processes, which we know exist, maybe we would have more medications out there that could treat all of these problems in a way that gives medicine the confidence to treat those conditions.
So this question from Francisco Pasquale from Frenchburg: what type of training will doctors receive prior to being able to prescribe medical marijuana?
Well, hopefully much more than they have right now. It's virtually non-existent in the medical school training for reasons that actually tie to prohibition. It's not asked about on what we call national board exams that all students take. But when I'm listening to the carve-out analogies, I'm sorry, I don't see it that way. But to the question real quick before you get to that. So does the medical licensure board then determine the training requirements and what's required? Because it's not specified in the bill, correct?
Right.
Different states have had requirements for extra education or not. Some of it's embraced, some of it's of a high quality standard. There are CME, or we call them continuing medical education, awarded credits as deemed by the American Medical Association standards that are available. But because it's not requisite, physicians that do that on their own initiative are to be commended. Right now, there is a severe learning curve that needs to be accomplished. And in deference to the caller before about epilepsy and other things that get carved out and trying to find solutions. Do no harm, strangely enough, is not part of the oath of medicine. It's a practice guideline that was established in the 19th century. But the Hippocratic Oath, Oath of Maimonides, all mention about treating patients compassionately with whatever tools are available and whenever necessary. These are the things that society bestows upon its healers, in this case licensed physicians, to help patients in that setting. Beyond there, the regulations, the compliance, the social concerns, and the public health concerns are things that are being discovered and falling in place. But this state's legislation, when I looked at it several months ago, did not have many of the elements it has now. And so compared to the 33 states that I know considerably about legislation, Kentucky's is light years ahead for patient outcome. And that's the key point.
And what do you mean by patient outcome?
Everything is driven in healthcare by patient outcome. It basically determines if something works or if it doesn't. So there are tools in medicine such that if an outcome, a bad outcome occurs, and they will in this arena, there are ways through accreditation processes and that same continuing education, not only from the physician, but the cultivator, the processor, even the distribution points, that are all germane to this. And without those kind of things that now have been added into this legislation, any legislator would be hard-pressed to justify why they were allowing a bad outcome to recur.
Gotcha. Yes, if there was, Mr. Shemelya, you've been quiet. I'll go to another question
Well,
unless you have a point to make.
I just think that the bad outcomes are occurring, and they're occurring all over the country because we can't regulate this substance. And it 33 times it's occurred. And here's the issue I see, and here's the first thing that's going to happen if you pass it this year is next year they're going to come to you. Because what you're passing is not only the highest concentration of marijuana, it's the most expensive in the market because of the concentration of THC. And you're going to have folks come to you and say, I can't afford this product. I need a smokable product, which is occurring in West Virginia, which they beat down last year, which has occurred in New York because they didn't allow smokable. And that is the cheapest form of this medicine, quote unquote medicine. And you're starting out with the most expensive, highly concentrated substance. So next year, they're already going to come to you and tell you we got to have smokable because that's what happens.
And so, Representative Nemes, would you entertain that? Would you go back and amend whatever KRS this bill were to become and say we're going to make it smokable now?
With respect to smokable, I've taken that out because it's required to pass the bill. I think if a physician says to their patient, a lot of folks understand that smokable is the quickest way into the body. And so I don't have necessarily a problem with smokable. So it's something I could support. I'm not going to mislead anybody. We took that out because it's required to pass the bill. So
Kentuckians for Medical Marijuana had tweeted to us that House Bill 136 limits cannabis to 35% THC and concentrates are capped at 70%.
Thank you.
Back to that discussion we had earlier. So is that satisfactory to you, Mr.
No, it's
Shemelya?
still way
It's
too high. Way
Right.
too high. Why do you need 35%? Show me the science that says 35% will do anything other than get you high.
That says 35% will do something effective?
that's the cap, right? That's the limit. So that doesn't require that every product has that in it. And we took that from a number of states that have already passed this bill. And a lot of states have no caps. I know we always hear about Connecticut. They have no caps on the concentrations of THC in their products.
And from a clinical sense, it makes no difference. What we're talking about is not the percentage, but the total amount consumed.
Okay.
And again, letting
Very
the patient
different.
decide what to take and how much to take.
Gentlemen,
Which this bill doesn't do.
We could have
does.
taken another 30 minutes on this, and I wish we had it. This has been a very good discussion, and we'll be following the bill on Wednesday. You can watch on KET, the Kentucky channel. You can watch it online. We will certainly be there at the House Judiciary Committee. Usually it's at 12 noon, and we'll be there for that hearing, and we hope that you'll tune in and see what happens in the next journeys of this bill. Join us Monday night as we discuss the state budget. We'll be almost halfway through the session. Thank you for watching tonight. You can always catch up on the week's news with Comment on Kentucky with Bill Bryant and the crew of journalists then. I'm Renee Shaw, and we'll see you next week. Take good care.
Watch Kentucky Tonight online anytime at KET.org.